surrogate endpoints. No, this doesn't have anything to do with in vitro fertilization necessarily. No, what you have here is you have death looking in the mirror. You have something that isn't the hard outcome you're interested in, but seems to be a reflection of it in some way. And we're going to figure out exactly how these work in the medical literature. So our goals are to define a surrogate endpoint and explain why they're so popular. We'll define what a perfect surrogate endpoint would be and try to convince you that they don't exist. And we'll remind you that there are only 3 truly hard outcomes in medical research. But to give you a sense of a surrogate in everyday life, we went out onto the streets and asked some people about their grade point average. How important is having a high GPA to you?
It's fairly important, yeah.
How important is your GPA to you?
I would say it's pretty important.
Very important.
Quite important.
My GPA represents who I am.
Pain is temporary, GPA is forever.
Why? Like, why do you care at all?
I mean, having a good GPA definitely helps in getting a job in the future. So.
And why is that important?
Mainly for jobs, yeah.
So would you rather have your dream job and a low GPA or a high GPA but a job you don't like in the end?
I'd rather have a great job and a low GPA, but normally the jobs that I'm looking at are looking for a high GPA.
So is it more important to you to get into that grad school of your dreams and have a low GPA, or would you rather have a high GPA but not get into the grad school of your dreams?
A low GPA and get into the grad school of my dreams.
Would you rather have a low GPA but go into the job of your dreams, or a high GPA but you get a job you're not too psyched about?
Ooh, probably the low GPA.
So would you rather have a high GPA or a good life in the future if you had to choose between them?
Probably a good life.
Definitely get a great job.
Would you rather get into the grad school of your dreams but have a low GPA, or have a high GPA but go to the grad school you weren't so psyched about?
Oh, the low GPA. Yeah.
So what did we see there? We saw that people can be really invested in their grade point average. They care about that number, right? It's an important number to them. But if you really push someone on why they care about their grade point average, it's not necessarily because they want the number to be higher. It's because they believe that that will lead to great things, that if they do really well in school, they'll get that job that they want, or they'll change the world in some way. So those great things, that's the hard endpoint. The GPA is just a surrogate marker for that endpoint. It's something that's related, but is not in and of itself important, except insofar as it's related to the hard endpoint. And it works exactly the same in medical studies. So what is a surrogate outcome in the context of a medical study? Well, it's some measurable thing that has some relationship to a hard outcome. So think of something like cholesterol level. Okay, you can measure it, and higher levels are associated with some outcome that's important, like heart attacks. Body weight is a potential surrogate outcome. Grip strength, how strong you are, might be a surrogate outcome, surrogate endpoint measure. Now, why do we care about these things? Why do we measure them at all? Well, there's a number of reasons. Oftentimes, the change in the surrogate marker, the surrogate endpoint, happens earlier in time than the hard outcome. So imagine we're talking about heart attacks, something that's important to avoid. Well, cholesterol level will go down, years before the heart attack actually occurs. So if I'm testing a new drug to prevent heart attack, maybe I just want to show that it reduces my cholesterol level. That only takes a few months, as opposed to treating someone for years and years and years to see if they have a heart attack or not. So there's a temporal issue here. Surrogate endpoints are often continuous. Remember when we talked about types of data? Continuous data, like your cholesterol level, right? It can change. It can be a whole range of values, not just high versus low, for example, a whole range of values. Those types of data give you extra statistical power to detect differences. And so the upshot of that is that if you're using a continuous outcome measure like that, you have to enroll less people in your study to find a difference if one really exists. And everyone likes to enroll less people in their study because it costs less if you enroll less people, so you save some money. So broadly, you're using surrogate endpoints to do cheaper, faster studies. And there's nothing wrong with that per se, except when something goes wrong with that. So let's talk about cholesterol and death. if I tell you your cholesterol level and you had never heard of cholesterol before, you would say, okay, right? You could imagine if I said, oh, your glep level is 146. You would say, okay, I don't care. My glep level why should I care about that? Well, the only reason you care about your cholesterol level is because we have told you over and over again that the higher it is, the more likely you are to have a heart attack and die. And really, that's the hard outcome we're trying to avoid here. None of us want to die. So are you really worried about your cholesterol level? Not really. You're worried about heart attacks and death. Those are the hard outcomes. But you know that there's a link between the cholesterol and those hard outcomes, and that's what makes you care about the cholesterol at all. So what is the perfect surrogate marker? And I'll tell you it doesn't exist, but here are the rules in case you're trying to come up with one. It must be correlated with a hard endpoint, okay? That's a given. Higher cholesterol, higher risk of heart attack. They have to be correlated in that way. Number 2, the disease process must be mediated by the surrogate. So I'll give you an example in a moment of where that's not the case. What that means is that the surrogate, let's take cholesterol, actually causes the disease in some way. Higher cholesterol, is depositing in the arteries and doing stuff that's going to cause the heart attack. It's not a passive bystander. The disease process must be mediated only by the surrogate. Now, this is one where you definitely go off the rails. That means that the only thing that causes a heart attack is high cholesterol. Well, of course, that's not true, and so this is where cholesterol falls apart as a perfect surrogate marker, but a lot of things fall apart here. It's very hard to find a disease process that is mediated exclusively by a surrogate. An example might be if we were to do lung biopsies, and our hard outcome was lung cancer, and our surrogate endpoint was dysplasia, an early cancerous change in the tissue. If I could prove that the only way you get to lung cancer is first passing through this dysplastic period, that's a pretty good surrogate marker. Of course, I'm still biopsying people's lungs, so it's not actually that useful. The practical upshot of a perfect surrogate marker is if you can reduce the surrogate, you will change the hard outcome. Because the surrogate mediates the hard outcome, the surrogate causes it. If I reduce the surrogate, I'll reduce the hard outcome. So let's talk a little bit about some surrogates that you might intuitively think are a good surrogate, but go a little bit wrong, okay? So here's an example of one that doesn't mediate the disease process. So prostate cancer is something a lot of men are trying to avoid. And again, what's the hard outcome here? What are we really trying to avoid? Well, death is a bad outcome of cancer. We don't want that to happen. So is the PSA level, this prostate-specific antigen that the docs are always trying to convince you to get, is that a good surrogate marker for the link between prostate cancer and death? Well, if it were a perfect surrogate, the higher the PSA level, the more likely you would be to die, and many studies can show that. But it would also mean that the PSA level mediates the death. In other words, the death is caused by a PSA being too high. Well, that's not what people die of in prostate cancer, right? PSA is not toxic. You're not poisoned by PSA. There's no connection between PSA and death. What is the upshot of that? That means if I reduced the PSA level without doing anything to the prostate cancer, if I filtered it out of your blood using dialysis or something, it wouldn't change your risk of death. It's just a passive marker. It is not a perfect surrogate endpoint. The closest I have found in common clinical practice to a perfect endpoint is something called SVR12 or SVR24 in the case of hepatitis C. So if you have hepatitis C, you're interested ultimately in surviving, avoiding death. And the best way to survive if you have hepatitis C is to be cured of hepatitis C. Now, up until about 10 years ago, we didn't have drugs that could reliably cure hepatitis C. Now we do have drugs that can cure hepatitis C in 98, 99% of cases. It's really quite miraculous. Okay, how do we determine if someone is cured? Well, you give the drug and you stop the drug after some period of time, and then you wait to see if the virus is in their blood or not. And so what the studies showed is that if they had sustained virologic response, SVR24, at 24 weeks after treatment, they're good as cured. In other words, the virus is never coming back if you can get to SVR24. So if we're looking at our hard outcome of cure, is SVR24 a good surrogate marker? Well, we know that it's correlated with the outcome because if you have no virus at 24 weeks, the likelihood is very good that you will have no virus ever again. So that's good. Does it mediate the outcome? Well, in this case, yeah, it does actually a little bit, right? Because you can't be cured if you still have virus in your blood. And so the eradication of the virus at 24 weeks does mediate the outcome of cure. So this is pretty close to a surrogate marker. But look, if we're really interested in survival, that third step you want to take with the surrogate is to say, okay, well, if I can increase the SVR24, will I definitionally increase survival? And the answer is not necessarily. While you may definitionally increase cure rates, what if, for example, the drug that you use to get to SVR24 is toxic, causes heart attacks, causes strokes, okay? So I may increase the SVR24 rate and paradoxically decrease the survival rate. So even this really good surrogate marker is not a perfect surrogate marker, probably because nothing is. Let me tell you a very cautionary tale about surrogate endpoints gone quite wrong. So the year's 1990, and the observational data said that after a heart attack, about 15% of people would die within the next 3 years. And when they looked at those people who died, most of the people had arrhythmias, these abnormal heartbeats. So the thought was, okay, arrhythmias is a good surrogate marker for death. It makes sense, right? You had a heart attack, now you have an arrhythmia, then you die, and certainly they were correlated. Did arrhythmia mediate the death? Well, yeah, people thought probably you have an arrhythmia and it causes your heart to stop beating. So if we can reduce the arrhythmias, then we can reduce the rate of death. This is a great surrogate marker. Well, lo and behold, a drug came out, a drug called Flecainide, which did reduce the risk of arrhythmia. So this is perfect. People have a heart attack, you put them on Flecainide, it reduces the risk of arrhythmia. We think that arrhythmias are causing the deaths, so Flecainide should save lives, right? Because it reduces the surrogate marker. Well, did it? I wouldn't be talking about it if it did, right? No, it did quite the opposite. The rate of death was about 3 times higher in the Flecainide group than the placebo group. What happened is that they put too much faith in their surrogate marker of arrhythmia. Flecainide did reduce arrhythmia, but people died of other causes. Some people think it's because the drug might have been potentially toxic. Some people think it wasn't the arrhythmias that were causing the deaths all along anyway. Arrhythmias were just an innocent bystander, much like PSA and prostate cancer. So you got to be careful. All right. The FDA is pretty strict about what can count as a surrogate marker when it comes to approving a drug, and this is the list as it stands right now in 2019. So they consider, for example, systolic blood pressure a good surrogate marker for the occurrence of stroke. So you can take a drug and say, well, if it reduces the blood pressure, then I can be fairly confident that it will reduce the risk of stroke. I won't read all of these to you, but you can see that there are not many here because the FDA, like you and I now, recognize that there aren't too many perfect surrogates out there. Remember, the question is always, what is the question? When you're evaluating a study and you're deciding, is this a surrogate outcome or is this not a surrogate outcome? You want to ask yourself, if these results are true, if I can change this surrogate marker, but it would have no effect on death rate, birth rate, or quality of life, would I use the intervention? And oftentimes, that helps focus you on what's a hard outcome and what's a surrogate outcome. If the outcome affects death rates, birth rates, or the quality of life, you can consider it a hard outcome. Anything else, not much. So if I told you I reduce your cholesterol with this drug, but it has no effect on your rate of death, your quality of life, or your fertility rates, for example, should you take the drug? Maybe not. So the take-home point, surrogate outcomes are cost-effective and quicker ways to do studies, but they are not hard outcomes. There are only a few that are considered valid by the FDA, and you might think of more or less that you consider valid. And really, in the end, there are only 3 hard outcomes out there: birth rates, death rates, and quality of life. Everything else, to some extent, is a surrogate marker for one of those 3. See you next time.